Greetings and welcome to another lecture in psychopharmacology. Today we're going to be right now, in this video, we're going to be starting the biological approaches. And we're starting with what people tend to think of when they think with biological approaches, and that is psychopharmacology. Now, psychopharmacology, psycho meaning psychology, pharmacology, well, pharmacy is where you get drugs. So, yes, it's basically different types of medications that are used to treat psychological disorders. The first grouping I'm going to talk about are the antipsychotics. Now, as I've mentioned before, psychosis is an old-time word for schizophrenia, so the antipsychotics are used to treat symptoms of schizophrenia or psychosis. Now, generally, these reduce positive symptoms of psychosis. If you go back to the schizophrenia lectures that I recorded, I talked about how it may be that positive and negative symptoms are caused by different things. Positive symptoms seem to be similar to too much dopamine, and negative symptoms seem to be similar to a brain injury. And so it would make sense that drugs would fix too much dopamine a lot easier than they would fix a brain injury. So generally they're useful for positive symptoms. This is not to say that drugs can't be used to treat negative symptoms. They can. It's just rarer and not as effective. Mostly these drugs are in pill form. People take the various pills. They're occasionally injected. I'm not, by the way, telling you the names of any of these drugs because I don't expect you to really know them. Names change constantly. Brand names in particular change all the time. So, I mean, essentially by the time this book was published, the information in it, when it comes particularly to medications, there's probably a little bit behind the times. So you don't need to know any of the names of these things. Just realize what antipsychotics are and what they do. Now, like all drugs, there are side effects. All drugs have side effects. Herbs that are drugs have side effects. I mean, things that aren't drugs have side effects. Water has side effects if you drink too much or too little of it. So the side effects of the antipsychotic drugs, particularly the sort of the traditional ones, the first generation ones, the ones that truly changed psychology and allowed so many people that before would have been hospitalized for essentially the duration of their lives to now lead relatively normal lives. These antipsychotics are mostly pills, and they do come with side effects. Although usually the side effects are preferable to the symptoms of the disorder. And that is something that anyone taking a drug has to decide. Is the benefit that I'm getting from the drug worth any possible side effects? The major side effect for these drugs is what's called tardive dyskinesia. And tardive dyskinesia is involuntary movements, generally of the face, sometimes of the mouth and tongue, almost like tics, but they can be a little more extreme than that, somewhere between tics and Tourette's. And from what I know of a lot of people who've taken these drugs, they prefer the tardive dyskinesia to the schizophrenia. Now, what can be done, tardive dyskinesia is particularly tricky in that if the symptoms are allowed to really take hold, they don't necessarily go away once a person is off the medication. When you're fooling with brain chemistry, in this case changing the amount of dopamine in the brain, some changes might be permanent. Dopamine has to do with symptoms of schizophrenia. It also has to do with movement. So what doctors do nowadays is when patients are put on these antipsychotics, they are watched very, very carefully. And as soon as they start showing any signs of involuntary movements, of tardive dyskinesia, they're taken off that drug and put on another. And usually what will happen is the symptoms will then stop. They haven't had time to become established. Other symptoms, other side effects are things like weight gain and diabetes and such. There's not as much that can be done with these because these are general side effects of this category of drugs. But again, it's something that needs to be taken into account. Hopefully, the weight gain can be dealt with by other means, and the diabetes perhaps might be able to as well. You always have to weigh the pluses with the minuses. And generally with the antipsychotics, the pluses make it worthwhile. Anti-anxiety drugs, perhaps not surprisingly, work on anxiety. And the broadest category of these are the benzodiazepines. Yeah, I am going to ask you to know the name benzodiazepine because It's not a brand name, it's a category name, and it is something that you're going to be running into that you've already run into in this class. Now, what these do is they are essentially depressants. They slow down the activity of the central nervous system. And so with low doses, they tend to reduce anxiety. In higher doses, they've been used for years as sleeping pills. Because, of course, depressants can also serve to, reduce activity in the central nervous system enough to cause people to go to sleep. By depressant here, we don't mean that they become depressed as in the mood disorder depression. We're talking depressant as in it depresses, it slows it down. Now, how this works is it increases a neurotransmitter called GABA. And what GABA is it's an inhibitory neurotransmitter. The more GABA you have, the less activity you have in the brain, because the GABA serves as an inhibitory agent. So therefore, what these drugs do, what these benzodiazepines do, is they increase GABA, which reduces activity of the central nervous system. The major problem with these drugs is their really high potential for dependence. Both physical and psychological dependence are very possible. And also, these are dangerous. There is a very good chance of overdosing on these as well. Because you take too much of a depressant or you mix one depressant with another, like mixing benzodiazepines with alcohol, a person can basically wind up depressing themselves out of breathing, which is not good. So doctors tend to regulate these very, very, very carefully. In fact, it's very difficult to get these sorts of drugs. Many doctors nowadays may give these benzodiazepines on a very limited basis for short-term use. Generally, they're not even used for sleeping pills anymore because the same problem occurs. There are other medications that can be used to help people sleep. But what these are done, or what these are used for, what is used instead of these for a lot of people with anxiety are actually the SSRIs, antidepressants, that I'm going to be talking about in a little bit. Because they also tend to reduce anxiety and they don't have the problems with dependence and overdose that the benzodiazepines do. But they take a lot longer to take effect, anywhere from 3 to 6 weeks to take effect. So there are pluses and minuses as there are with everything. Next, the mood stabilizers. Now with mood stabilizers, what we're talking about here are drugs that are used to treat bipolar mood disorder. While bipolar disorder and unipolar disorder are both mood disorders, you cannot use the same medication to treat both. In fact, when a person is given a medication for an SSRI, they are usually given some sort of test to make sure that they don't have bipolar. Because if you give somebody with bipolar an SSRI, it's not going to do them any good, and it may actually make things worse. And you don't want to give someone with unipolar a treatment for a mood stabilizer simply because that's not going to help what they have. And in fact, a lot of these mood stabilizers are kind of dangerous. The traditional mood stabilizer is a salt of the lithium ion. And I was glad to hear that this is a lithium salt and not lithium by itself, because if you've taken chemistry, you know that if you mix lithium with water, it tends to explode. And that would be one hell of a side effect. Now, lithium salts don't explode. They will, however, destroy your liver very happily. I mean, they're toxic. And the trick here is, as is the trick with a lot of other drugs, is to give enough of the drug in order to get an effect without poisoning the individual you're giving it to. So people who are on lithium need to be regulated very, very carefully. Now, we know that lithium stabilizes moods, but quite frankly, we haven't the slightest idea how it works or why it works. It was just found out that people who are taking lithium or who have water supplies with lithium in them, it's a naturally occurring element in some areas, tend to have less mood disorder. But yeah, we really don't know why or how, but it does tend to work. Now, in addition, we can also use anticonvulsants as mood stabilizers. Anticonvulsants are used to treat seizures. And it's kind of interesting that drugs that are used to treat seizures can also be used to treat bipolar disorder, because it almost makes you want to think that maybe bipolar disorder is some kind of really weird seizure. We don't know. But we do know that it works, and that it works like that. Next, we have the antidepressants. These are for use for for unipolar mood disorder, not bipolar, but unipolar. Now, the traditional SSRIs, the traditional antidepressants are drugs like MAOIs, monoamine oxidase inhibitors. This is one of the first antidepressants back in the 50s and 60s. These work by inhibiting enzymes that break down norepinephrine and serotonin. Norepi is how I abbreviate norepinephrine because it's a very long word. And we know that increased amounts of norepinephrine and serotonin tend to increase mood. So we're simply stopping the breakdown of these neurotransmitters to increase mood. The problem with MAOIs is that they have some nasty side effects, most notably something called the cheese effect. When a person taking MAOIs eats foods that contain tyramine, which I believe is an amino acid, it's found in cheese and some other substances, hence the name cheese effect, it can cause a person's blood pressure to skyrocket with bad results for them. So that's a fairly nasty side effect. Tricyclics were also very early antidepressants, so-called because they have 3 circular structures in their chemical makeup. They also work on the reuptake. They inhibit the recycling of norepinephrine. They work a little on serotonin, not as much as the MAOIs do, but they work a little bit. But tricyclics are one of those global drugs that can really get into a lot of other things other than simply what you want them to do. They can actually affect lots of other things as well. And so these are one of the things that we generally don't use very much if other drugs will work better. And specifically, the other drugs that work better are the SSRIs and the SNRIs, the selective serotonin reuptake inhibitors and the selective norepinephrine reuptake inhibitors. That's what the N is for. These were first developed back in the mid-1980s, and they were revolutionary in their own way, simply because they work very well on depression as well as anxiety, and the side effects are relatively mild. We have no cheese effect. We have no other real big issues here. The side effects are things like nausea and diarrhea, and, nervousness and insomnia and sexual problems being, for the most part, lack of sexual desire. And none of these are life-threatening, although some of them may make life less worth living, but they're not life-threatening. And so, combined with this and the fact that they're also not addictive, SSRIs and SNRIs in the first generation and second generation and so forth are still used in large quantities to help treat these particular disorders, which they do well, although remember, first of all, we don't know what long-term use of these will do to people's brain chemistry. I guess we'll find out. And secondly, remember, all of these, we're not treating the problem. We're simply treating the symptoms. One more antidepressant I want to talk about is one called bupropion, or Wellbutrin. This is not an SSRI or an SNRI. It's not a tricyclic. It's not a MAO inhibitor. It does the same thing, but it does so in a slightly different way. And it's been found, actually, that not only is this useful in terms of depression, but it also can be used to help smokers quit smoking. Because there is something about Wellbutrin, we have no idea what it is, really, but there's something about Wellbutrin that people who take it don't have the same intensity of nicotine cravings as they did before they started taking it. A lot of drug uses get found this way. The SSRIs themselves were originally for use as a weight loss drug because a lot of people on them lost weight. But the reason they lost weight was probably because they were no longer depressed. And so they started using it for depression instead. And this has been used very often and pretty successfully, considering very little helps with getting off nicotine, to reduce the nicotine cravings and allow people to stop smoking or vaping. The other thing that's nice about Wellbutrin is it doesn't have the sexual side effects. It does not kill people's sex drive dead the way that the SSRIs and the SNRIs do. So for a lot of people who have partners and who would actually like to have a sex life, this may well be a better option. And if they're smokers, it may help them get off that as well.